Hi and welcome back to another video of Medic Notes. This video will be on systemic lupus erythematosus, short form SLE. SLE is a multi-systemic autoimmune disease where autoantibodies are made against a variety of autoantigens, for example the anti-nuclear antibody ANA, which then form immune complexes. And when there is inadequate clearance of the immune complexes, it will result in a host of immune responses, which cause tissue inflammation and damage. And environmental triggers may play a part in SLE as well, such as Epstein-Barr virus infection. So the prevalence, it affects more female than males, where the ratio is around 9:1. So females are more prone to have SLE, typically women of childbearing age. The symptoms of SLE. SLE is a remitting and relapsing illness of variable presentation and cause. The features are often non-specific, which are malaise, fatigue, myalgia where there is muscle pain, and fever. They can also be organ-specific and caused by active inflammation or damage. Other features include lymphadenopathy, loss of weight, alopecia, nail fall infarcts, non-infective endocarditis, also known as Lippmann-Sachs syndrome, Raynaud's, stroke, and even retinal exudates. These are some of the symptoms that could be presented by the patient. For investigation, more than 95% of the cases are ANA positive. However, the most specific antibody would be the anti-dsDNA antibody. It is highly specific, but only positive in around 60% of the cases. Besides that, we can do the complement studies to check the C3 and C4 level, where they are expected to be low due to the consumption of complement. ESR and CRP is the investigations for SLE as well, where ESR is high and CRP is normal. So whenever there is someone who has a multi-system disorder, high ESR but CRP is normal, think of SLE. If the CRP is high, think instead of infection, serositis, or arthritis. This is the diagnostic criteria for SLE. So they are divided into the clinical and laboratory criteria. Clinical criteria, there are 11 of them, which includes acute cutaneous lupus, where the patient have malar rash, chronic cutaneous lupus, which consists of discoid rash, later I will show the pictures, non-scarring alopecia, oral or nasal ulcers, synovitis, where there are 2 or more joint pains, serositis, which can be divided into pleuritis or pericarditis, at the lung or the heart. 7 is presence of proteinuria or red cell cast, where there is renal features. 8 is neurological features. 9, 10, and 11 are more towards hematological disorders, which are hemolytic anemia, leukopenia, and thrombocytopenia. Whereas for laboratory criteria, some of the criteria are positive ANA, anti-dsDNA, anti-Smith antibodies, anti-phospholipid antibodies, and those are for the autoantibodies. For complement studies, low C3 or C4, and positive direct Coombs test to suggest hemolytic anemia. So how do we diagnose SLE? So if there are 4 or more criteria present, where at least one of them is clinical and one of them is laboratory criteria, we can diagnose SLE. Or there is a biopsy-proven lupus nephritis with positive ANA or anti-dsDNA, we can diagnose. So this is for the diagnostic criteria. Let's take a look at the rashes. So this is a picture of malar rash, where there is fixed erythema, either flat or raised, over the malar eminence, and they spare the nasolabial folds. So this is malar rash, which is a significant finding for SLE. The second picture shows the discoid rash, where there are erythematosus raised patches with adherent keratotic scales and also follicular plugging. So think of it as a three-stage rash affecting the ears, cheeks, scalp, forehead, and chest. So first there is erythema, then it progresses to pigmented hyperkeratotic edematous papules, and then progress to atrophic depressed lesions. Moving on to management of SLE. If the cases are complex, we should involve the specialists for SLE or nephritis clinics. The general measures for SLE include high factor sunblock and also hydroxychloroquine reduces the disease activity and improves survival. For maintenance, we can give NSAIDs unless there is renal disease, and also give hydroxychloroquine for joint and skin symptoms. For skin flares, we can give topical steroid. So depending on the flare of the SLE, whether it is mild, moderate, or severe, if it is mild where there is no serious organ damage, we can give hydroxychloroquine or low dose steroid. If it is moderate flare where there is organ involvement, may require DMARDs or mycophenolate. If there is severe flares where there is life-threatening event or organ-threatening condition, for example hemolytic anemia, nephritis, severe pericarditis, or CNS disease, they will need urgent high-dose steroids, mycophenolate, rituximab, and cyclophosphamide. So these are some of the management we can offer, and this is all for this video. Thank you.